Hello, I'm Donald McCauley, and welcome to medicsvoices.com, where we speak to the key opinion leaders in health and medicine around the world. Today, I'm speaking to Victor Montori. Victor's had a fascinating medical career, beginning in Lima, Peru, and now as a consultant endocrinologist in the Mayo Clinic in Rochester, Minnesota. Tell me a little bit about your career.
I finished medical school in Lima, and but my training was coincided with very tumultuous time in Peru with hyperinflation and terrorism, which destroyed the infrastructure of the country and limited severely the ability to grow professionally. There was a lot to do, and I struggled with the decision to stay or to pursue further training. Opted to pursue further training, applied to a million different places in the United States, and through this lottery system that allocates these spaces, I ended up in Rochester, Minnesota at the Mayo Clinic. For a couple of years, I was in Canada on a scholarship with working with Gordon Guyatt at McMaster University in Hamilton, Ontario. But for the last 21 years, I've been on staff at Mayo, and I spent now about a third of my time seeing patients, mostly patients with diabetes. I'm an endocrinologist. And outpatient care, and then the other whatever's left of the percentage of 70% of the time, I'm not good with numbers. I do a research on healthcare delivery and patient-centered care, and then for the last, I don't know, now it's eight years or so, developed a nonprofit organization focused on turning away from the industrialization of healthcare, which I believe is one of the reasons why all this work on patient-centered care seems to bump against a hostile environment within healthcare, and develop a global movement for care, for careful and kind care for everyone, which now is, I think, the work and passion of over 150 fellows from 6 continents and 10 countries around the world, and many more who find hope in this work.
Let me take you back a little, because for most of us, to be an endocrinologist in the Mayo Clinic seems to be the pinnacle of a career in healthcare. But you see a lot of problems in healthcare. You think there's a crisis in healthcare?
Yeah, well, my personal ability to and to have the resources and the colleagues and the support that I need to practice medicine and diabetes care at the highest level possible is of course an incredible privilege and incredible blessing. I like to think that on good days, the teams that I work with and the ability that we have to offer that care does help and support some of the patients that we see in ways that I hope they find valuable. My personal situation does not preclude me from observing what is, I think, a fundamental challenge, right? So many of my patients, I mean, I have very few people, except perhaps very young patients with type 1 diabetes, but very few people that only have diabetes. Most people have now multiple ongoing chronic conditions, and they, more than anyone else, experience all the pathologies of the healthcare system, right? They'll come through the system either through our acute care doors, our emergency department. They will be frequent participants in primary care in all its different modalities, virtual, in person, triage phone lines, portals on the electronic medical record, and then specialty care, oftentimes multiple specialties coming on to try to provide care. And so they touch the elephant from every side, and they find the elephant lacking. But also they become overwhelmed by the task of navigating all that system, implementing all the different care plans that are sometimes negotiated, oftentimes foisted on them, and being able to enact that on a day-to-day basis, while at the same time they're trying to live lives which are often also highly complex and problematic. So just from my own interaction with our patients, you see that there's something fundamentally wrong about the healthcare system, in that the people that we're seeking to help are becoming overwhelmed and frustrated by the ways in which we are interacting with them. My own colleagues, you have to be completely unaware of reality to fail to recognize that we have a huge crisis, not only of attracting the best and the brightest into what I think is the most wonderful, calling and career, which is to care for your fellow human. We have difficulty attracting young people into it, keeping them in this profession. And some of the most experienced caring people leaving the profession, exiting care earlier than they planned, because they can't take it anymore. They are tired, they are frustrated. They're frustrated because they know what the right thing is and they can't make it happen. Or they can make it happen, but at an incredible cost of administrative burdens that they need to overcome, and silly policies that indicate to them clearly that nobody trusts them, trust their judgment or trust their honesty. And then at the same time, we have massive problems of financial sustainability of all this, plus the environmental sustainability, given healthcare's significant carbon footprint on the planet. So it's a massive crisis of care at the human level, at the economic level, and at the planetary level. So yeah, I am very worried, even if I'm working in medical Disneyland.
Now, you said something about doing things right and the right kind of care. Now, bearing in mind that you came from the evidence-based center of the world in McMaster, and you're also very interested and promote the whole concept of kindness, how do we navigate the tension between those two? How do we differentiate between being a nice doctor and a good doctor?
Well, I need to first sort out the language there. So I like to think I'm nice and I like to think I'm kind. But when I talk about careful and kind care, that kind adjective that I'm using there, I'm using it less to indicate being nice, and I'm mostly using it to indicate my commitment to my kin. So that I have to be respectful of my patients' goals and priorities in life, which rarely, and of course is never, but I'm going to be generous and say rarely includes being a great patient, right? And as a healthcare professional and as an agent of a healthcare system, I have to be very careful with the limited time, energy, and attention that the patient and their family have for healthcare. And I find that it is often the case, I think, in our own arrogance, that we think that if the patient is sick, what else is there for them to worry about or to think about? They should prioritize this thing that I'm telling you to do and so forth. And we oftentimes have people come in for appointments expecting that they can wait hours to see us, or that they can go back and forth to different parts of our system, which are not well connected and not well integrated and not co-located. And they can just go one place to the other and move around because, what else is there to do? And yes, they can self-manage, and measure everything, and of course write it down or send it to us, and all of these things, I think, reveal a lack of fundamental respect for the fact that these people are trying to make a living in the broadest sense of that word. And not only is disease and illness interfering with that, but also our care. And so my use of the word kind reflects this desire to be fundamentally respectful for the fact that people have other reasons for living. And this is an interruption. And what we need to try to do is to provide and to create care plans that fit in a minimally disruptive way. To that extent, there is no disconnect or tension with evidence-based practice. And then the job of the clinician is to co-create a plan of care that draws from that evidence for people like this, to create a plan of care for this person. And that is where careful care comes in. So careful care is evidence-based, kind care is respectful, minimally disruptive care. No tension. It's part of our goal. That's what medicine is for me.
When I hear you talk about careful care and kind care, it strikes me that you sound a rather unusual revolutionary. So tell me about the patient revolution.
This one is about fundamentally, radically changing the conditions in which we care, and in which people receive care. This revolution is sincere. I sincerely mean that we need to fundamentally change healthcare, but it's also nonviolent. And it's revolutionary in intent, changing the fundamentals, but it is its mechanism of success, I would say, is more about eroding the dominant approach today and creating and fostering and building an alternative that will eventually overcome in frequency and in prevalence and in impact the dominant structure today. So it's more of a erosion of the existing and a replacement with something better, rather than the destruction of the existing without constructing an alternative. And if we don't construct an alternative, we will leave people without the care that they need, which will not, again, be the most caring thing we could do. And so, this is why a revolution for care has to be a caring revolution as well. And it's one that is very hopeful, because if you look carefully today, in healthcare, we have a coexistence of some of the worst ways in which we can care for people and some of the best ways. And the problem is that some of the worst ways are the ones that are dominating. And so if we could just change that balance and make the better ways, the more careful and kind ways, the dominant approaches, the ones that are most likely to be experienced by patients coming to see us, then we'll be successful.
And putting this into action, what are the steps we can do as individuals and organizations to make this happen?
There are several things. One that is, in this conversation has already come up. One that is close to my heart is the notion of language. We rarely speak, when we talk about healthcare, we rarely speak about cruelty. And yet, when you go seeking care into healthcare, and what you experience instead is indifference, that's fundamentally cruel. When you're looking for care and somebody slaps a label on you as a non-compliant patient, and that prevents you from getting a fresh look from another clinician to try to help you, that's fundamentally cruel. And cruelty should be considered a never event in healthcare, like amputating the wrong leg. And this is to illustrate the power of language. I think we need a language of reform, of revolution, that calls out the pathologies of care, the kinds of distortions of care that industrialized healthcare does. And so we speak, for instance, of seeing patients as a blur, when your clinician may have the impression that they know you because they've looked at your medical record, but has no time to ask you about who you are and why you're famous. We talk about burden, the burden of treatment, and we've discussed a little bit about the unkindness of overwhelmed patients. 70% of our patients with multiple chronic conditions, 40% of them, 70% are overwhelmed, are burdened. 40% are overwhelmed to the point where they're about to stop doing something potentially life-saving as a result of how much work they have. So we talk about burden. We talk about hurry. And while everybody's celebrating AI as perhaps the most significant innovation in healthcare in our time, I keep insisting that the most important innovation in healthcare today is the unhurried conversation. As the space, as a sandbox in which patients and clinicians can come together to fully understand the situation of the patient, not as blurry, but in high definition, and then to co-create a plan of care that is not overwhelming, but rather fits well with the patient's priorities and the patient's situation. So we talk that language that I'm using, I think is an initial step that we want people to begin to start calling out these pathologies of care and identifying the ways forward that are going to deindustrialize the healthcare system. So that's one step. The second step is to decide to act. And every person, every one of our Patient Revolution fellows has a sphere of influence. That sphere of influence could be quite limited. Could be limited to where they work, in behind the desk, or in an office, or in the hospital, or in an administrative position, or perhaps on a leadership position. Perhaps they're board members, perhaps they're policymakers. They have different spheres of influence, and we talk about micro revolutions. What could you do within your sphere of influence to bring about a change that you think may have a chance of addressing one of these pathologies of care? To give you an example, you are a lowly medical student, and you choose to start by describing their personal and social situation, rather than describing their age and the disease with which they present. You don't need permission for that. You just need to do it, and somebody to notice, and then to catch on, and now you have a mini revolution that you're doing within your spheres of influence. If you're an administrator and you're in a committee meeting, and somebody says, I know we should just ask the families and the patients to do this, because we don't have the resources to do it. You should be that person in that room that says, hold on, we need to assume that our patients and families are overwhelmed, and this transfer of work to them, it might be good for us, might make us more efficient and higher value, but it's actually landing on people who are going to be quite tired and overwhelmed, and this will not be the most caring thing we could do. How about? So, these small mini revolutions, I think, are the next step to try to populate. If this was a pond, we will be bringing invasive species in to try to overwhelm the existing species of industrialized fish that are there. And so I think the goal is to keep doing this. And then as an organization, what Patient Revolution does is three things. One is we have a school, so we help people understand and use this language, understand and use these concepts, and understand change and how they might conduct these revolutions. We have a greenhouse where we try to develop new ideas and tools to help people at the front lines undertake this, and then we create a community that gives people courage to continue to act in these ways and elevate and communicate what they've learned when things haven't worked out, and the massive successes that they're having when they act here and now. And with that, we hope that we can continue to promote a movement for care of global reach.
Victor, thank you very much for that wonderful, optimistic and enthusiastic message. I took one phrase that for me is the action that everybody can take, and that's the action for the patient being the unhurried conversation. Victor, it's been an absolute pleasure talking to you. Thank you very much indeed.
A pleasure. Thanks for having me.